I'm Roger Kim, an assistant professor of medicine at the University of Pennsylvania. I'm an interventional pulmonologist by clinical training and a physician scientist dedicated to optimizing the thoracic oncology diagnostic process. Yes, thanks so much for having me. So first off, lung cancer screening with low-dose CT chest imaging has been recommended by the U.S. Preventive Services Task Force since late 2013, and it's been covered by CMS since 2014 because it has demonstrated to reduce lung cancer-specific mortality by about 20%. Importantly, adherence to annual lung cancer screening has been suggested as a quality metric for lung cancer screening programs because in the large, well-conducted randomized clinical trials that form the database for, recommending lung cancer screening in the first place, the vast majority of lung cancers were actually detected during subsequent rounds of screening after the baseline round of screening, meaning after 12 months after the initiation of screening. Um, also in these clinical trials, adherence rates to annual screening longitudinally were reported as greater than 90%. And microstimulation modeling data from the CISNET group has also suggested that, incremental decreases in longitudinal annual rates of adherence correspond to decreasing benefits of lung cancer specific mortality related to screening. And so really it's been kind of suggested and widely thought of as being an important quality metric for lung cancer screening programs. The big issue though is that the previously existing literature in this space using kind of real world observational data to look at adherence rates to lung cancer screening were really limited largely to only one round of screening. So meaning that, folks were looking at, including ourselves out of the Prosper group, looking at, the immediate follow-up to the initial round of screening. And we're not able to look sort of longitudinally at multiple rounds of screening, number one. And then also number two, there's really not been, a clear demonstration that adherence to annual lung cancer screening actually corresponds to increased lung cancer detection rates and, hopefully early lung cancer detection rates, in real world populations, like how had been demonstrated in randomized clinical trials. And so for those two specific reasons, we decided to undertake this study to try to answer, again, number one, what are the real world rates of longitudinal adherence to annual lung cancer screening across 3 rounds of screening? And then number two, is real world annual adherence actually associated with lung cancer diagnosis rates and early detection of cancer? Yeah. So to conduct this multi-center retrospective cohort study, I again collaborated with members of the Prosper Lung Consortium, which comprises of Kaiser Permanente, Colorado, Kaiser Permanente, Hawaii, the Marshfield Clinic in Wisconsin, Henry Ford Health System in Michigan, and the University of Pennsylvania Health System, where I work. The main objectives were, again, to estimate annual lung cancer screening adherence rates and to examine association between, lung cancer screening adherence, incident lung cancer detection rates, and cancer stage distribution across those 3 rounds of screening. So, I think it's really important just to highlight a couple key features of the design of this study that, differed from prior studies. And in order to do that effectively, unfortunately, I am going to have to get into some of the weeds in sort of like definitions and some of the kind of statistical kind of planning that we decided to do. So to kind of back up even before I get into that, though, the big thing here is really what we're talking about is adherence, right? And I think it's important to talk about how adherence has been defined and how we defined adherence. So, to be clear, in this study, we developed and tested a brand new, novel, pragmatic, in my opinion, definition of longitudinal screening adherence solely based on the baseline screen lung RADS result. So what's LUNGRADS? Just for listeners who may not be as familiar with this scoring system. So it stands for the Lung CT Screening Reporting and Data System, abbreviated as LUNGRADS, which was first introduced by the American College of Radiology in April of 2014. And since then, it's really become widely adopted and really the standardized approach to communicating lung screening lung cancer screening results. LungRad's scores can range from 1 to 4, with increasing numeric values corresponding to increasing estimated risks of lung cancer as determined by the reading radiologist. A simplified way of interpreting LungRad's results, and has been used by us previously and other observational studies and others, is really to kind of further categorize LungRad scores into negative and positive results. So negative results encompassing LungRads 1 and 2, and positive results encompassing LungRads 3 and 4. So why do we do that? What does that mean? LungRads 1 essentially means that no nodules were found at all, meaning that it was basically a completely normal scan. LungRads 2 is really a very clearly benign nodule. So very small nodules where the radiologist is able to say, can say with pretty high confidence that this is not anything that we need to worry about. And importantly, for both LungRads 1 and 2 negative baseline screens, the recommendation for follow-up is just to continue with annual screening. So meaning get another low-dose CT in 12 months. For LungRads 3 and 4, it gets a lot more complicated. So for LungRads 3, which indicates a probably benign nodule as determined by the reading radiologist, the recommended follow-up interval is 6 months. And then for LungRads 4A, meaning a potentially suspicious nodule for malignancy, the recommendation is actually a 3-month low-dose CT or a PET scan. And then for 4B, 4X, it gets even further heterogeneous. And the recommendation really is you can do sort of anything. You can get an immediate a CAT scan, you get a PET scan, you can get a biopsy, you can get a surgical resection, and really kind of, the jury, frankly, is out as far as what the best thing to do among those high suspicion of malignancy nodules. And so the critical thing about how adherence has been measured in prior studies is that some folks have been try to be very kind of by the book, so to speak, in trying to actually capture exactly those various different heterogeneous follow-up metrics for LungRad 3 and 4. And others have been a little bit more liberal, looking at wider ranges among that first round of screening. What we decided to do, for the first time in this study, is to say, if we're looking at adherence across multiple rounds of screening, two things have to be true, right? First of all, patients should not have been diagnosed with lung cancer during that round of screening, because otherwise, obviously, if they've been diagnosed with lung cancer, they're no longer eligible for screening because they've actually been diagnosed with lung cancer. So that's the first thing. And then the second thing is, among the patients with positive baseline screens, we really need to somehow account for this heterogeneity and what can possibly happen in the real world among people undergoing some of those various diagnostic testing that I just went over. And so what we decided to do is essentially phase shift by a couple months the kind of the interval for screening, annually among patients with positive baseline screens. And so what that looks like is we decided to take a very kind of liberal and all-inclusive approach to making sure that we did not underestimate adherence in our cohort. So just more specifically, among those with negative baseline screens, we looked at adherence at T1, meaning at the second round of screening, and then T2, meaning the third round of screening, and defined among those with negative baseline screens adherence at T1 as any repeat chest CT between 10 and 18 months for T1, and then 22 to 30 months for T2. And among those with positive baseline screens, we defined adherence at T1 as any chest CT between 11 and 21 months, kind of allowing for that heterogeneity and what might be happening in that immediate kind of couple months following the initial screen. And then adherence at T2 at 26 to 36 months. And so really what we think we're trying to capture here is trying to account for that heterogeneity that we see in real world practice when folks have a positive baseline screen. The other important thing I wanted to highlight in how we constructed our cohort is that we ensured that all of the individuals included in our analytic cohort had at least 36 months of follow-up. And that's really, really important whenever you're trying to look at a metric like this that requires you to be able to actually ascertain the outcome of interest, which in this case is adherence. You need to make sure you have enough follow-up time to actually adjudicate that outcome. And we were very careful in making sure that each of the individuals included in the analytic cohort had at least 36 months of follow-up so that we could accurately capture, both the outcomes of adherence and then, of course, the lung cancer diagnostic rates that I'm sure we'll talk about as well. So those are just a few of the highlights of our kind of analytic plan that that I wanted to kind of go over that make our study distinct from prior studies. Yeah, what fantastic questions. Thanks for asking them. So to address the first one, and I'm really glad you brought this up actually. So the in the NLST, let's just use that as an example because frankly, adherence rates were actually not reported very well in Nelson. In the NLST, they did a very simplified approach to adherence. They said at time T0, which is defined as when they got their baseline screen, we're just going to look at 12 months after that to define T1 and then 12 months after that, so 24 months after T0, to define T2. And what they did is they said anyone who comes back within -1 and +3 months from those sort of goalposts at the 12-month and 24-month mark will count as adherent. And of course, in the context of a clinical trial, this is very different than in real world practice, where they literally had to come back and get their low-dose CT protocol within the clinical trial context. And so that's how they define adherence, whether they came back within, just to be more specific, 11 to 15 months for T1 and 23 to 27 months for T2, just simply defined as -1 +3 after the 12-month goalpost. What I would say to that is that's great for a clinical trial because that's what they were trying to do at the time. However, with the way we do things right now in real world practice, as I just reviewed with using the LungRAD scoring system, that sort of definition of adherence is obsolete. It frankly does not make sense because we know that folks who have a LungRADS 3 score, just to use an example, you need to come back for their interval scan at 6 months if you're following the recommendations. And then so assuming that no lung cancer is detected in the interim time, the next kind of round of screening, so to speak, would then actually be at 18 months, right? 12 months plus 6 months is 18 months, which would not even fall in the definition of T1 adherence if we were to use the NLST definition. And so I think it's actually a really critical thing to highlight. And this really gets back to my point I was just making previously, which this really only applies to those with positive baseline screens. So those with LungRADS 3 and 4 scans, because the immediate follow-up that happens after one of those positive screens happens is very heterogeneous and frankly is quite different than what was going on in the early 2000s for the NLST, where we didn't have robotic bronchoscopy. All we had was TTNA. People were getting a lot more surgical resections, things like that. So, I'm really glad that you brought that up. So that's how, frankly, it was defined. Adherence, quote unquote, was defined in the NLST, which, frankly, in my personal opinion, sort of is not relevant, frankly, to what we're actually doing in current day practice. To address the second question that you had, which is, well, if I'm, running a lung cancer screening program and I'm trying to enroll patients into my screening program, why did you exclude these people that were lost to follow-up? It's a great question. So what I'd say to that is, the way that I designed this analytic cohort for this study should frankly have nothing to do with how someone is clinically implementing their lung cancer screening program. Because the question or the hopefully the thing that you're trying to do if you're running a screening program is you're trying to retain all of your patients, you're trying to enroll them, you're trying to do all the things that you should be doing for a high quality performing program. And that should be the things that should drive your metrics that you're looking at. In our situation with doing this, study, our sole purpose of doing the study were to do those two things that I mentioned previously, which is to look at adherence rates, among people who are, enrolled, who are eligible for, being, captured to, that we're able to capture within our data set to be adherent and to see what the lung cancer kind of detection rates were. In order to, just I guess a basic clinical epidemiological principle is that you need to be able to adjudicate the outcome in the data set that you have. And if folks are sort of not, if we're not even able to capture, based on the limitations of our data set, which I'm sure we'll talk about later, if we're not able to capture whether or not they came back or not, then we actually cannot say whether they were truly not adherent or not, or whether they were truly, detected with lung cancer or not. And so in order to try to maintain the internal validity of our data, we were, unfortunately, it was one of those decisions we had to make in order to make sure that the data we were publishing was valid. Yeah, absolutely. And thank you so much for mentioning that. As an interventional pulmonologist myself, I'm, very privy to, and quite sensitive to that, that exact point that you're making. So unfortunately, when you're using, real world electronic health record data, as in our case here, it's really, really challenging to be able to sort of make sure that you're accurately capturing each individual step along the way in that process. That being said, we actually did do just that in a prior publication where we were looking at racial disparities in annual lung cancer screening adherence that was published in Annals of ATS in 2022, where we actually did very painstakingly go through all the different procedural records to see what proportion of folks with lung reds 4A, 4B, 4X were actually getting, the bronchoscopies, the mediastinoscopies at the time, their TTNAs, their surgical resections at the time within those first 5 months after having a positive baseline screen. And so I would refer our listeners to looking at, some of the details that I included in the supplement of that study for a more kind of specific breakdown of looking at what happens in the real world, just to kind of further prove your point that, that further downstream diagnostic testing is 100% incredibly important and necessary, frankly, in order to obtain a tissue histologic diagnosis of lung cancer. That said, again, coming back to the purpose of this follow-up study, using the same data set, it was, really that understanding that there is a lot of heterogeneity that can happen after you get the initial screen. You need to have that initial screen or that follow-up screen in this case in order to even be able to take on those additional necessary diagnostic procedural, diagnostic workup steps in order to diagnose lung cancer. And so our goal here in this particular study was to not get stuck in the weeds of figuring out exactly how many bronchoscopies people had, but just simply to say, if you were to at least, at the bare minimum, follow up and get your follow-up CAT scan in the time frames that you frankly should be getting them done based on the recommendations by lung rads, are we even seeing any kind of association whatsoever between that simple metric and lung cancer detection rates? Because if we don't even see any link between that very kind of rudimentary, kind of crude estimate of adherence that we employed in this study, with an actual hard outcome of lung cancer detection rates, then sort of what are we even doing here, right? I think that's kind of the way that we were looking at it. So it's a very kind of low-hanging fruit, so to speak, question. Like, if we were to just do what we should be doing, getting people back annually to get their lung cancer screened, or at least getting some form of CAT scan so that the clinicians who are taking care of these patients are aware of what's going on in their lungs in these intervals, is that in and of itself associated with an increase in lung cancer detection rate and hopefully in, earlier stage shift as well. Yeah. So, the key findings were kind of broken down into two parts, I'd say. So the first, like I said before, is just how does adherence change over time, longitudinally? So what we found was that adherence at T1 was around 61%. And then that actually decreased by about 10 percentage points to 51% at T2. So the first key finding here is that overall adherence around 60%, and then it actually decreases annually over the subsequent rounds of screening. The other thing with regard to adherence specifically that we found was that if you were adherent at T1, you were also more likely to be adherent at T2. Meaning, of course, the opposite being true. If you were not adherent at T1, you're also less likely to be not adherent at T2. So that was the other kind of key finding with regard to adherence. And then with regard to lung cancer diagnosis rates, we found that 2.7% of all the individuals included in the study over all 36 months of follow-up time were eventually diagnosed with lung cancer. The timing of when they were diagnosed with lung cancer was as follows. So within the first round of screening, so from 0 to 12 months after baseline, 1.3% of individuals were diagnosed with lung cancer. During the second round, or round T1, as we called it in the study, 0.7% were diagnosed with lung cancer. And then in the third round, or round T2, 0.8% were diagnosed with lung cancer. So again, very similarly to the NLST and the Nelson trials, if you collectively look at the subsequent rounds of screening and add all those numbers of patients that were diagnosed with lung cancer up and compare them to the baseline round of screening, overall, again, as we saw before, most patients were ultimately diagnosed with lung cancer after the baseline round of screening, so after that first 12 months of screening. We importantly, as we've alluded to already earlier in our conversation, we were able to demonstrate that adherence at both T1 and adherence at T2 were associated in a statistically significant fashion with lung cancer detection rates at T1 and T2, meaning that if you were adherent over three rounds of screening, you were more likely to be diagnosed with lung cancer than if not. Again, this is not sort of like groundbreaking news that if you can't find a cancer unless you're looking for it, so to speak. And it just kind of proves the point, though, that if you were to look at adherence as defined in the way that we define it in this study, at least, you are able to find an association with increased cancer detection rates. And then maybe more substantively, at the T2 round, so meaning the third round of screening, we were also able to demonstrate that among lung cancers detected among those adherent at T2, there is a higher proportion of early stage or stage 1 and 2 cancers as compared to those who were non-adherent at T2, suggesting that truly we're actually doing what lung cancer screening is supposed to be doing, which is finding early stage cancers which are potentially curable, as opposed to later stage 3, 4 cancers. Absolutely. Yeah. Thank you so much for asking those questions. They're really, really important questions. So I'll address the first question first, as far as causation versus association. So absolutely, with any observational data, even if you use fancy statistical modeling to try to do causative inference, which we did not do intentionally for this study, because to your point, we were not trying to make a causative association between, the exposure of adherence and the outcome of lung cancer diagnostic rates, which we're explicit about in our analytical plan and our methods section. Um, the reason why we didn't do that is because we didn't need to. The NLST and the Nelson trials did do that. That was the whole purpose of those randomized controlled trials, which is frankly the only way you can really try to make that as direct association between, is screening actually linked to, improvements in lung cancer outcomes. So that, fortunately, in our case, we didn't have to do, because it's already been done. That is the exact question that was being answered in those randomized controlled trials. So the whole, again, purpose of our trial here was just, if we were to look at this super crude, super simplified metric of adherence that we have nearly defined, as we already talked about previously, was that even associated with any differences whatsoever in lung cancer diagnostic rates? Because if the answer is no, then I think we have to ask ourselves a lot more questions, getting at what you were bringing up earlier about the messiness of how we do our clinical practice, because we don't practice within a clinical trial. Then at that point we have to start questioning a lot of things, right? Whether or not those results from the NLST and the Nelson trial are indeed actually applicable, frankly, to the real world. I think that's really the main thing that we were hoping not to find, which thankfully we did not. But that really was sort of the purpose of this trial. Like, is even looking at adherence, is this even something that we should be doing, right? And thankfully we obviously did not find that. And for that explicit reason, an association is actually quite informative when you're using this level of messy real world data like you were mentioning. So to address the kind of limitation of our study, as you alluded to, of the fact that we use electronic health record data, which includes a lot of things that we cannot control for, that we don't know about because of the way data is collected in an EHR. That's one of the primary reasons why we purposely used a very broad definition of chest CT follow-up. So prior studies have also differed on this. And of course, this also differs from the LUNGRAD's recommendations themselves, which explicitly say that you should be getting, exclusively a low dose CT for follow-up, longitudinal rounds of screening. We intentionally did not define our adherence definitions as that, because of the fact that in the real world, not everyone actually orders a low-dose CT for follow-up of routine lung cancer screening. People sometimes order normal chest CTs, diagnostic CTs, all kinds of different things. So that's one reason why we chose to include any type of chest CT within our definition. So that's number one. The number two thing is, at the end of the day, from a kind of real world clinically practicing, myself as a clinically practicing physician right now, it sort of doesn't matter how someone knows that they have something suspicious going on in their lungs. Whether it's someone goes into the emergency room because they have chest pain and they happen to get a CTPE protocol and they accidentally find a nodule that wasn't there the previous round, in my opinion, it kind of doesn't matter, because that patient will then hopefully get the follow-up care they need in order to work up that nodule. Meaning, really, whether it's quote unquote incidentally detected or screen detected, as long as you're eligible for lung cancer screening, which we know that our patient population was, because we only included, current or former smoking individuals. We didn't include any people who never smoked any cigarettes at all, right? That it sort of doesn't matter, as long as they're getting the CAT scan within the general ranges they should have been getting that anyways, then presumably they should be hopefully getting the downstream care that they need after that. And so we kind of leveraged the fact that we had the messy real world data in order to see what's actually going on in the real world. And that, I think, is the true kind of strength and generalizable nature of the results that we. No, thank you. That's a great question, and frankly, I know that that at least as this paper went through review, this was one thing that came up quite a bit, and I've had had private conversations with colleagues about this concept as well. And here's what I'll say to that, and I guess I'll start off by also saying that I know others are actively working on potential different definitions of adherence as a quality metric that differ from the one that I propose, which, I am 100% okay with, just to be upfront about. So I guess the point of this study was not to necessarily say, hey, you need to use this exact definition of adherence that I used in this particular study in order to, have all these downstream kind of like, punitive metrics and things, kind of making sure that we're keeping on to these very specific intervals that I define in this particular study. That is not my intention whatsoever. I think the intention here is just to highlight that in some fashion, I do strongly think that programs do need to have a way of at least knowing internally what the rate of their own patients that are enrolled in their individual screening programs are coming back for screening, because hopefully, at least, my study, other folks' studies, and of course the NLST Nelson trials that were randomized control trials have already demonstrated, in my opinion, the importance from a at least data point of view, the importance of adherence. So what I'd say to that is, I think this really highlights the need for each individual screening program to have some sort of internal registry, some sort of formalized way of kind of following and keeping track of the patients within their screening programs. Our prior study, which I alluded to before, published in the White Journal 2022, and others, Lori Sakota, for example, published a really impactful study in 2021 in JAMA Network Open, also demonstrating the same thing, which is the importance of centralization of a screening program. Centralization has been defined differently by different folks, different researchers, and even clinically. But generally speaking, I think most of us would agree that the concept of program centralization includes essentially having some sort of dedicated staff, whether that's a patient navigator, patient coordinator, a nurse navigator, somebody whose job it is to basically do what I just said, making sure that we're keeping track of folks to make sure that we know when they need to come back, to make sure that they do come back, to make sure that the orders have been placed, to make sure that all that interval, diagnostic workup happens that you brought up previously, making sure that they have their biopsy schedule, things like that. That has definitely been shown, I think, pretty definitively to have an impact on both adherence and uptake for lung cancer screening programs. And so I think this just sort of further highlights, the potential need for some sort of, more standardized approach to centralizing a lung cancer screening program in general. And so I think that's, in my personal opinion, the kind of the hopeful takeaway from my study, just kind of emphasizing the fact that, it's really not enough to just get someone screened for lung cancer, right? I mean, we already know that uptake of lung cancer screening is unbelievably poor and is way, way worse compared to you know, um, our friends who are doing colorectal cancer screening, prostate cancer screening, cervical cancer screening, breast cancer screening. Those uptake and adherence rates are in the 80% plus range. Our uptake of lung cancer screening is anywhere between 5 and 15% if you look at the kind of most recent data. And that's just uptake, right? And I think what I've hopefully been able to help provide some additional data for is that uptake is not enough. That's a good start, but we have to also make sure that we're looking at adherence over time in addition to uptake. So I think there's basically just so much work that needs to be done. This is really just the tip of the iceberg, in my opinion, but 100% agree with you that, I think there needs to be some really careful thought. If we were to use or formally implement adherence specifically as a quality metric, there needs to be really a lot of careful thought in determining how to define that because of some of those kind of tricky issues that we just went over. Even from a research perspective, it's even trickier to define in a kind of clinical implementation perspective. Thanks so much for that question. Um, So unfortunately, the short answer to the question is that there's really nothing we can sort of glean from the data that is included in the study, as you alluded to, just simply because of the time frame that we were looking at. But to your point, I think it's going to be really important for future studies to look to see if there is any kind of difference, with the advent of some of these, novel technologies that you just mentioned over the past, I'd say 5, 6 years or so. And I think I'm sure there will be, and I hope there will be some future, real world observational studies that look directly at that. I think there's a lot of complexity in how to interpret the impact of some of those advanced diagnostic techniques that you brought up. It's interesting. We're actually completing right now a qualitative interview study where we actually sat down and interviewed 40 pulmonologists, interventional pulmonologists, and thoracic surgeons across the country to see just what folks are doing as far as working up pulmonary nodules when they're first identified, whether by screen detected or incidentally detected. And I'll actually be presenting that preliminary data at the 2025 ATS conference in San Francisco. But the take-home message essentially is that folks do things very differently at different places. As I alluded to, as I've tried to highlight multiple times during our conversation today, among those with positive, long-range 3 or 4 baseline scans, that degree of heterogeneity is extreme. Okay. And that part, I don't think necessarily has changed. That concept of heterogeneity, I want to say, just to clarify, has necessarily changed that much over the past 10, 15 years. I think the nature and the details within what constitutes that heterogeneity, of course, has changed over the past 5 years with the advent of robotic bronchoscopy, intraoperative cone beam CT, steerable needles, things like that. But I think the jury's still out about sort of what impact that will have from a population-based perspective, like what the study was meant to be, long term. I guess just to, without getting into too many of the weeds regarding that kind of topic, which I think is a whole other maybe subject of a different podcast. a couple take-home messages, though, that I do want to leave listeners with when interpreting those types of data, when incorporating those types of more advanced diagnostic techniques, would be, what the prevalence of malignancy is in the individual cohort being studied is probably the number one most important thing to be considering. There's a, pretty widely cited and relatively well-known paper. Published by my mentor, Anil Vachani, just a couple of years ago, looking specifically at that. It was a modeling study where basically we're looking at diagnostic yield rates from diagnostic bronchoscopies and varying the different, multiple different factors. And the one that influenced the outcome the most was cancer prevalence. And just to put that a little bit in layman's terms, what that means is that if you're a thoracic surgeon and you're only being referred nodules that are extremely high suspicion of malignancy, and your actual malignancy prevalence in your cohort is like 90% or higher, that by definition, you're going to get a very different kind of diagnostic approach than, let's say, if you're, I don't know, an unbelievably aggressive interventional pulmonologist who goes after a 4 millimeter nodule, then your prevalence of malignancy in your patient population is probably going to be significantly lower, probably closer to the 20-30% range, which is going to change the ultimate outcomes from a risk benefit ratio perspective for your patients. And just to put that a little bit more succinctly, if you're doing more procedures and diagnosing fewer cancers as a result, then the relative risk of your procedures that you're going to be performing, even if your pneumothorax rate is only 1 to 2%, is, objectively going to be higher than for someone who's only doing procedures on, patients that almost certainly have cancer, if that makes any sense. And so I think it's going to be really important to take into consideration both the procedural risk and the potential benefit of diagnosing cancer in some of those studies that you're alluded to moving forward. Yeah, great question. So I guess the overall answer to your question will be I will direct the listeners to some of the excellent work being done by one of my colleagues, Dr. Fabian Maldonado out of Vanderbilt, who's actively trying to tackle that question head on by performing, high volume, high efficiency, pragmatic clinical trials to rapidly assess novel technologies. And he's been quite successful at that with recruitment and, ultimately, even presenting some preliminary results at ATS 2024 last year. And I think there's going to be some more to come this year as well. So I just make sure that readers or listeners rather are aware of some of the great work that he is doing to directly trying to do both, basically have your cake and eat it too. Both do generate high quality randomized controlled trial evidence in the context of a rapidly changing landscape. That said, obviously it's not possible to do a randomized controlled trial for every single, potential clinically relevant question that we have that comes up in the changing landscape that we live in. So what I'd say to that is that, I think it's important to look at the quality of observational data that's published, right? Not all observational data is created equal. So it's really important to make sure that the question being asked can be answered by the data being presented or analyzed for any given observational study. And in some cases, there's some really important, I think clinically actionable things that we can glean from well-conducted observational studies. So that's one thing I'll say. Use the data that we already have that we're actively generating in order to actually learn, things from it without having to do a clinical trial. So that's, I guess, one thing, just, I guess, food for thought that I strongly believe in. The other thing is that I think, each individual health system has to sort of, unfortunately, the way it is right now, because of the fact that not every institution, for example, has the same availability of the diagnostic capabilities that we just talked about, right? Not every institution even has an interventional pulmonologist, for example. So may not even have access to performing, advanced diagnostic bronchoscopy, for example, and may only have access to transthoracic needle aspiration performed by an interventional radiologist, or even just, a wedge biopsy from a surgeon. So I think that's one of the key limiting factors to try to make, sort of more generalized, like we talked about quality metrics or even recommendations nationwide or even statewide, even countywide, right? So I think it's really important to remember that. And so what that means is that each individual, and that my hope, one of the takeaways from my study is that each individual health system comes up with their own internal way of being able to at least do the best they possibly can in ensuring kind of longitudinal follow-up, whatever that might mean for the individual health system. So, I don't think it's obviously reasonable to mandate that everybody has the exact same technology available at any given, institution, and nor I don't, do I think that's sort of practical or financially feasible from like a just like a practical perspective. But what I do think is important is that each individual institution should at least be trying their absolute best in investing resources to ensure that whatever their standard of care is can be equitably and consistently implemented across all patients being screened for lung cancer. Yeah, thanks so much again for the opportunity to highlight our work and the importance of this question. So what I'd like to, I guess, leave our listeners with is just a reminder of really how devastating lung cancer is and how big of a problem this is in our country, in the United States and worldwide. So first of all, just to summarize, 1 in 16, or 1 in 16, people will be diagnosed with lung cancer in their lifetimes. So what that means is that almost every single person in this country and in the world will know someone personally who is affected by lung cancer. And so this is a really, really prevalent disease. And as you mentioned earlier, it is actually responsible for the most lung cancer related deaths in the United States and worldwide. So I just cannot overemphasize the importance of this type of work. We really need to do a better job at improving our lung cancer outcomes. And one of the ways, not the only way, but one of the ways is by effectively implementing lung cancer screening, which we've talked about already, has not been done very well so far. The people who need to be screened are not being screened at a high enough rate, number one. And even among the people who are being screened initially, they're not getting the follow-up care that they need at the rates they need to be getting them. And so I think, just to kind of put our study into context, I think this is just another piece of data that just helps to highlight the point that we need to do better, overall as as an entire kind of medical profession, at each individual healthcare institution, and then ultimately even down to the individual clinician practicing. We all need to feel the sense that we need to do better, because our patients really depend on it, and frankly this can truly save lives. Just making sure folks come back to get a CAT scan. It may seem so simple, and like we've talked about over the course of this podcast, it's just such a kind of, I guess, messy metric, so to speak, but it's just such a simple thing. Just getting a CAT scan can potentially, literally help save someone's life by diagnosing lung cancer earlier and hopefully helping to eventually chip away at those deaths that we talked about due to lung cancer. So I think that's really the biggest thing I want to that I want our listeners to take away from this. As far as future directions, I think they're really innumerable. One of the ones that I wanted to highlight, though, is that there are a lot of folks that are actually already in the process of conducting clinical trials, looking at adherence as an outcome. So they're trying different interventions to look to see how can we actually improve adherence. And of course, longer term, hopefully they'll also be collecting data on lung cancer outcomes as well. There's a lot of really great work being done in that space. A couple, I wanted to just shout out. One of my colleagues and mentors here at the University of Pennsylvania, Catherine Brendel and Anil Vachani, are actively enrolling folks in a pragmatic clinical trial looking at telehealth interventions as part of a large P50 grant, looking at exactly that. How can we actually increase rates of adherence over time? One of my colleagues out of Washington, Maddie Triplett, is doing some excellent work as well, looking at certain underserved populations and seeing how we can do a better job increasing adherence rates in that population. As like I alluded to before, we know there's also disparities in who is more likely to be adherent or not. And so those are just a couple, snippets. And there's other great work being done by other groups. I don't want to, make that seem like that was a comprehensive list, but there is ongoing, really fantastic work that's happening to see what types of specific interventions programs can undertake in order to increase adherence. So, those are ones that I'm really looking forward to seeing what the results will be. And then other, things that I think need to be done are to figure out, like I alluded to before, program centralization. Which specific aspects of program centralization are the most important? We still don't know. Is it just that you need a patient navigator? Is it that you need to have a registry, like I alluded to? Is it that you need to have, X, Y, Z that, to make it the most streamlined and most effective way of making sure that the patients who are screened for lung cancer get the care they need? We still don't sort of know. Here locally, at one of our hospitals within the University of Pennsylvania Health System, we recently implemented a new program called the Lung Watch program, which is a fully centralized program that's meant to hopefully do just that. We're sort of still in our infancy for that program, but the concept is kind of what we've been talking about: establishing a registry, having staff dedicated to making sure folks get the care that they need up front, and then longitudinally over time. And I think obviously we're going to be looking very closely at the data resulting from that program internally. But I think there's just so much work that needs to be done. And I think the other important thing to remember is that we're all in this together for the benefit of our patients, and hopefully we can sort of make a lasting impact for them.